Di group 3
Yes, Doctor.
Harun Nabila, you nak tu?
Yeah, I continue from yesterday.
Come.
Okay.
Hanun Nabila ke Harun Nabila? Hanun.
Haun.
Hanun. Hanun apa maksud dia bahasa Arab?
Hanun tu maksud dia penyayang ada.
Oh, okey. I tak tahu pula maksud penyayang.
Before this, doktor ada tak student nama Hanun?
Tak ada. Saya first time dengan nama you
Tak
Hanun.
lah.
Yeah. Okay, come.
You all can see my screen now.
Nampak tapi putih ke apa?
Itu video ada.
Okay, come.
Okay. Assalamualaikum warahmatullahi wabarakatuh. I'm Hanun and I will continue my presentation yesterday. Actually, we stopped at central intravenous line, which is one of the type of intravenous therapy. And this central intravenous line is like we insert catheter into the large vein of the central circulation system. So we will take a look at this video lah, simple.
You are watching this video because your child is scheduled to have a central venous catheter, also called a central line, put in. The purpose of this video is to explain what a central venous catheter is, how the catheter is inserted, what it does, and how to take care of your child's catheter. If you have any questions after watching this video, please ask your child's central line care nurse. A central venous catheter is a slender, hollow, flexible tube that is inserted into the arm or chest through the skin into a large vein. The doctor has chosen a central venous catheter so that the healthcare team can deliver fluids, nutrition solutions, antibiotics, chemotherapy, or blood products directly into your child's bloodstream. The catheter can also be used to collect blood samples so that the healthcare team doesn't have to collect blood with another needle. The doctor will choose one of the following catheters based on your child's needs: Mediport, TEC, or Breviac. The central venous catheter will have one lumen or multiple lumens based on the therapy needs of your child.
So let's do the central intravenous line. Actually, the insert into the supravena cava into the right atrium. Okay, for this one is the complication and management for intravenous therapy. For the first one is the patient has venous spasm, which is pain along the vein. Sluggish means like slow rate lah when claim is completely open. So this is probably because of there is severe vein irritation from irritating drugs and fluids. So sometimes it could be by administration of cold fluids or blood. So how to manage this is that we apply warm socks over and surrounding the area, and also use blood warmer lah for blood, or prepare red blood cell when appropriate. So the second one is it could be thrombosis, which is painful red swollen vein. So this is because the injury to endothelial cells on the vein wall, and also allow platelet to adhere and thrombus to form. So we can manage this by remove the device and restart the infusion in opposite ligament and apply warm socks. So to prevent this, also you have to use proper venipuncture techniques to reduce injury to the vein. Okay, that is for intravenous therapy. Next one is venipuncture. Okay, venipuncture usually if we use for laboratory testing where we need a needle, it's used to take blood from vein. So So venipuncture also be done to remove extra red blood cells from the blood to treat certain blood disorders. So next, usually puncture site for venipuncture is depend on the volume of blood we need for the procedure and also the type of laboratory test to be done. And for neonates, we prefer to do venipuncture because it causes less pain. Okay, this is the equipment for venipuncture. Okay, first we use a wing stem needle with 23 with an extension of the tube. Usually people call this as a butterfly because it's shaped like a butterfly there at the needle. Then second one, we use a string with a barrel from volume 5 milliliter depending on collection needs. Also for the evacuated tube, also 1 to 5 milliliter and lower vacuum. Also we use safety equipment with the needle covers to minimize blood exposure, prevent any sharp injury. For the procedure, okay, the first one, we just collect all the equipments and also from hand hygiene to decrease the any contamination. And also we have to immobilize the baby because we know that children are like very active. So we have to, as a parent operator, we have to make them stay still because this thing is sharp. So we don't want to injure them. Then we put the pediatric tourniquet just above the venipuncture site. And then we put on the glove and then we priming the equipment. Prime equipment meaning that we prepare all the equipment before we do the insert the needle. Okay. And then attach the end of the wing infusion set to the end of the vacuum tube. Insert the collection tube into the holder. And then we remove the plastic shaft from the end of the butterfly. Okay. Next, we're gonna disinfect the collection site and allow it to dry. And then we use thumb to draw the skin just about 2 fingers below the venipuncture site. And then we push the vacuum tube completely onto the needle until the blood begin to flow into the tube. And then if you want to fill in multiple tubes, just carefully remove the full tube and replace with another tube. Take care not to move the needle in the vein. And then after we collect the required amount of the blood, we release the tourniquet. And then okay, this one we put the dry gauze over the venipuncture site and slowly we draw the needle. And after that, we ask the parent to apply some high pressure on the venipuncture site to prevent any blood leakage from the site. And then we remove the butterfly from the vacuum tube holder and we dispose the butterfly into the sharp bin provided and dispose all the contaminated supplies. And also don't forget to label the tube of the blood we collected to with patient education and numbers, and that, don't forget about that. And then we put adhesive bandage on the patient. Also remove gloves and also hand hygiene. Okay, that is the procedure of venipuncture. Okay. So next, this is like the actually in venipuncture in neonates, there will be some difficulties. So this video will explain how to strategy how to tackle that difficulties.
Dah.
There's a video for venipuncture.
There's 3 complications that make going from neonates difficult.
Win.
Yes?
Apa continue difficult win? Okay, ha.
Okay, yeah, difficulty in neonates.
2 is that we have to always stabilize our lives. And even when we conquer those challenges, we still have to obtain adequate volumes. What about solutions to hard-to-find veins? I like to consider hand veins.
Wow.
They're often more developed than the intravenous veins. We also want to make sure that we're using a pediatric tourniquet. Every pre-block will increase in the flow of blood to the area by a function of 7. You can also use wet palpation. You know what I mean by wet palpation? If you take your finger and say an alcohol prep, that wetness reduces the surface tension as you're pumping and enhances your ability to feel the contour and resiliency of the vein because the liquid serves as a lubrication that eliminates the dry skin sensation that can mask the feel of the vein. Something that's considered an acceptable alternative for humans, but it does require training and technique. I've been years drawn from a scalp vein, not when I attempted. I simply not been trained. In fact, I've only witnessed it once and that was unsuccessful. But for the record, scalp veins are an acceptable alternative for neonatal punctures, but require specialized training. Of course, we want to recruit an assistant and to obtain adequate volumes. Again, is important, but let's also use a syringe so that we can control the negative pressure that's applied inside the vein. So we use a syringe with gentle pulling pressure to help obtain adequate amounts of blood in addition to pre-warming. Other solutions for performing for those situations in which we get lesser volumes of blood. So that the laboratory can get a full volume of tubes to make sure we submit to the laboratory they are filled to the that the active ratio is maintained and not submit unfilled tubes that threaten test results.
So that is for like difficulty of drawing blood from.
Tak apalah, bunyi tok. Okeylah. Dengar tadi?
Ada
Your
bunyi
punya
apa dah?
Wi-Fi you problem ya?
Saya pakai mobile data ke?
Ya?
Pakai mobile data.
Mobile data, patutlah.
Lepas tu saya tak pakai earphone. Semacam direct daripada laptop punya speaker.
Tak apalah, it's okay.
Okay,
Next.
Okay, next. Ni complication.
Ada
Management.
lagi?
Ni last doktor.
Okay.
Okay. So, usually hematoma formation because of blood leaking into the tissue lah. For example, if the needle is puncture the vein and the blood leak into the tissue, so patient will present with rapid swelling at or near venipuncture site. So if hematoma begin to form during the venipuncture, the collector must remove the needle immediately and apply the pressure. And this also apply the pressure over the puncture site at least 2 minutes lah to relieve. Also, if patient complain about pain or swelling, we can use cold or compress or ice pack. For the second one is dizziness. So this is referring to state of loss of consciousness resulting from insufficient blood flow to the brain because of withdrawal blood from the patient. So the collector must notice for sign of alert, hyperventilation, vertigo, dizziness, and lightheadedness. So if the patient have faith, so the collector must discontinue the procedure by release the tourniquet, discard the needle. Okay, so to prevent from patient injury. Okay, that's all, doctor.
Okay. Siapa next?
Ni doktor, Fatina Jiha.
Siapa?
Fatina Jiha.
Fatina Jiha. Okay. Topik.
Nasogastric or gastric tube insertion.
Okay.
Okay. Can you all see my slide?
Okay. Boleh nampak lagi? Tak ada, tak nampak.
Belum lagi. Alright. Nampak?
Tak ada.
Tak ada lagi?
Tak ada lagi.
No?
Dah nampak.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Fatina Jiha binti Kamaluzaman, metric number 1810610, and I will be presenting about nasogastric or gastric tube insertion, or in short, NGT or OGT insertion. Okay. Now let us get to know more about NGT or OGT. Okay. It is defined as a tube which is passed into the stomach via the nose in the case of nasogastric, or mouth in the case of orogastric, so that the patient can meet his or her nutritional needs, or we can administer medication through the tube to rehydrate the patient and also decompression of the stomach. So this is the, if you can see my laser here, this is the flow or the passage of the tube into the nose or into the mouth, into the pharynx, downward into the esophagus, and down into the stomach. Okay, if there's a common complication whereby the tube is inserted into the trachea instead of esophagus, because the trachea is just positioned anteriorly to the esophagus. Okay. This is a picture of a patient which have undergone the procedure. Okay, there are some contraindications and caution regarding the procedure. A group of patients which are contraindicated to undergo this procedure are firstly if they is on post-operative period, specifically if it is involving the GIT. Okay. Secondly, if there is non-structural abnormality such as co-anatresia, whereby the nasal passage into the pharynx is blocked. So if we perform this procedure, the tube cannot go through. Okay. Thirdly, if there is recent caustic injection or corrosive injection. So because we're afraid if the procedure may cause trauma, so it will cause the condition to be worsened. Okay. In suspected spinal injury, because we may induce some swallow reflex, so we afraid that the patient may injure his or her cervical spine. Okay. In the case of known or suspected esophageal varices, chronic liver disease or liver failure, as well as bleeding disorder, okay, we afraid that we may cause trauma in the procedure. So if we cause trauma in such patient, they may experience non-stop bleeding. Upper GI stricture and obstruction, the same as the structural abnormality, the tube cannot pass through the obstruction. And in the case of suspected nasal, maxillary, oropharyngeal, or also esophageal trauma, we afraid that we may worsen the condition because trauma. In suspected base or skull fractures patient, because we just insert the tube into the nose, we afraid that the tube, instead of going downwards, it may go outwards into the intracranial area. Okay. So in the group of patient which we have to take special consideration, it is involving patient with altered level of consciousness, diminished or absent gag reflex, and or impaired swallow and significant developmental delay, because during the procedure we may induce or we may instruct the patient to swallow. So if the patient is has impaired swallow reflex, cannot perform swallowing, or cannot comprehend the instruction, so it may cause the procedure to be much more difficult. Okay. And the usage of anticoagulants or impaired blood clotting also due to the trauma and tracheostomy also. And in the case of gastroesophageal reflux and chronic eating disorders with vomiting, because this condition may be can be more complicated if we insert the feeding tube or the nasogastric tube. Okay. Other than that, there are also risks if we insert the tube in the patient. So first and the most common risk, of course, mainly due to the misplacement of the tube. Instead of going into the stomach, it go elsewhere. Okay. Firstly, is pneumonitis. Okay. Why pneumonitis? Usually it happens because when the tube is misplaced into the trachea, and then the placement of the tube is not confirmed yet. However, feeding is proceeded. Then the food will enter the trachea instead of the stomach, so it will cause infection and pneumonitis. Okay, in the case of intracranial insertion, such as I've mentioned before, especially in children that has a base skull fracture, instead of the tube going downwards, it go upwards into the intracranial area. Okay. Thirdly is aspiration, which is associated with tube dislodgement, whereby the tube is inserted into the trachea. And then to confirm the placement, we need to aspirate some gastric fluid. However, when the tube is in the trachea, then the aspiration is not the it's not the gastric content, but the trachea mucus. Okay. The next complication or the next risk is trauma to the surrounding GI tissues. Okay, this is clear. Pneumothorax also may occur in some cases. However, the mechanism is not really clear. Okay, and in the case of when the tube is inserted correctly into the stomach, because there is continuous and spontaneous feeding, then okay, continuous feeding. It may cause feeding intolerance, abdominal pain, poor absorption of medications through the tube, and also diarrhea to the patient. Okay.
Dah slide sebelum?
So
Slide sebelum tu. Sebelum tu. Sebelum. Okay, selepas. Okay.
which one that ni?
You continue.
Okay. All right. Okay. So now let us proceed to the preparation
Okay.
and procedures. Okay. Preparation prior to the procedure. Okay. First of all, we have to take verbal consent and explain the procedure properly to the patient and to the patient's guardian. Okay. And next, we need to identify the patient's name and the patient's details, and we have to take note if there is any allergy, because in some cases the tube cannot be inserted through the nose, because the nasal passage is edematous because there is allergy. Okay. And prior to the procedure, we need to prepare all equipment. In the next slide, I will explain. And then the setting also must be appropriate, whereby this procedure is usually performed in the treatment room, where to secure the patient's safe environment. Okay. And then we need to observe the patient's heart rate and respiratory rate prior, and document them in the medical record. And because the procedure may cause discomfort to the patient, so we may consider prescribing analgesia. However, we have to take extra caution because sedation may cause the gag reflex or the swallow reflex of the patient to be impaired. Okay. And in the case of orogastric, if the patient's mouth is dry, then we need to moisten. We may moisten the patient's mouth with mouth swab. Okay, these are the equipment needed. First of all, of course, the nasogastric or orogastric tube, with or without the guide wire. If we using the one with the guide wire, then after we have complete the insertion, we need to remove the guide wire. Next one is non-toxic marker pen to mark the measurement. Okay, and then lubricant. We need it to lubricate the tube before inserting it. Syringe for to obtain the gastric fluid. Yes, litmus paper is to test the pH of the gastric fluid, and tape is to secure the remainder of the tube. Okay. Okay, the gastric tube comes with different sizes according to different ages of the patient. So usually in newborns, we use the size of the tube, which is up to 8 Fg. For infants and children up to 5 years old, we use up to 10 Fg. And for children over 5 years old, we use the gastric size, which is up to 40 mg. However, in patients with developmental or physical delay, it may they may indicate it to use the gastric tube sizes which is much smaller to make it easier to be inserted. Okay. Okay. Before the procedure is began, we need to make sure that the patient is positioned correctly. So if the patient is an infant, then the infant needs to be wrapped in a sheet or in a cuddly. If the patient is a toddler or a child, then he or she should be sitting and securely held at the head and the arms. Okay. And the child should not lean forward and the neck should not be extended because when the neck is extended, the epiglottis is open. So it may lead to misplacement of the tube inside the trachea. All right, okay, now let's go to the procedure. Okay, first of all, before inserting, we need to estimate the desired length for the tube that have to be inserted. So what we have to do is measure the length of the tube in the case of nasogastric, starting from the tip of the nose. In the case of orogastric, starting from the bridge of the nose. Okay, extended it around the cheek, extended it at the cheek and around the ear, and then down to the xiphoid and to the umbilicus. Okay, to make it even clearer, I will invite my niece to perform some demonstration. Okay. Cak. Alright, okay, this is my cute niece. Her name is Sharha and she is 4 years old. Okay, I hope you can appreciate. Okay, imagine this as the tube. Can you see? Okay, imagine this as the tube. So, started with the tip of the nose. Okay, and then at the cheek, around the ear, to the xiphoid. Okay, and down to the umbilicus. Okay. Okay, and then from the xiphoid to the umbilicus, okay, our desired length is up to the halfway of this length. So around here. So when we have the desired length, mark this area with using the marker. Okay. Dah, kasih. Nah, cukup. All right. I hope the explanation is clear. Okay, next, after we have marked the desired length, then lubricate the tip of the tube using the lubricant, in this case using the KY jelly. And then after we have lubricated it, insert the tube gently into the nose or into the mouth of the patient, and only until the marker area, only until the if we do not have the marker, then we may simply just memorize the length. Okay, only up to that desired length insert the tube. Okay. Occasionally, along the insertion, instruct the patient to swallow. If it is an infant, we may use a pacifier or a dummy to have the sucking reflex and swallow reflex. Or we may induce some startle reflex by blowing into the patient's face like that. And then the patient will startle and induce the swallow reflex. Okay. In the case of an older child, we may ask them to sip, to take a sip or two of water to induce the swallowing. Okay. And then along the insertion, we have to observe if there is any excessive gagging, coughing, wheezing, apnea, or any color change, because it indicates that the tube is incorrectly, it is misplaced into the trachea instead of into the esophagus. Okay. And also along the way, if there is any resistance, withdraw a bit around 1 cm or 2, and then rotate slowly, laterally, and downward. Okay. Okay. The procedure is not considered successfully done without we confirm the placement of the tube. So to confirm the placement, we need to aspirate a small quantity of gastric fluid from the tube and then check the pH of the gastric fluid. Usually the stomach contents have a pH of up to 4, up to 4.0, yes. Okay. However, in patients that consume or under acid suppression therapy, we may consider the pH to be up to 5. Okay, and then when we after we have done with the procedure of confirming the placement, ensure that the length of the tube remains unchanged. That the area that we have marked earlier or that we have memorized, ensure that it remains unchanged, and then we can safely anchor the remaining of the tube with the tape at the patient's sheath. Okay. However, in some at-risk patients, we may consider X-ray to confirm the placement, such as in patients with gastric acid pump inhibitors or gastric pump continuous feed, because their gastric content pH may not be under 4. Okay. And then with in patient with diminished or absent gag reflex, and with the patient with an altered level of consciousness. Okay. This is a simple algorithm to check the tube position. Okay. I think this is clear. We need to test the pH and proceed to feed if it is less than 4. If not, consider the patient. We need to ask the patient to if or continuous feed, and then consult medical officer. And we accept the pH up to 5, and then we can proceed to feed. However, if the gastric content is not obtained, then do not commence feed. We need to turn the patient into the left side, and then wait for at least 30 minutes, at least 15 minutes, up to 30 minutes, and then re-aspirate. Okay. If the aspirate is still cannot be obtained, then check again the length of the tube that we have inserted at the tip of the nose, the marked area, or the one that we have memorized earlier. Okay, and then or maybe reposition the tube 1 or 2 cm in or out, and then re-aspirate again. However, if it is still cannot obtain, then never ever commence any feeding, because we are afraid that the tube may be misplaced. So first seek senior medical assistance, and then consider removing all of the tube and reinserting all of it over again from the very first step. And then if it is still unsuccessful, we can obtain X-ray for this patient to confirm the tube position. Okay. All right. After the procedure is done, we have to document them in the medical record. But yes, before that, we need to comfort the child, because the child may crying or grunting during the procedure. So first comfort the child, and then dispose all the equipment and undertake the patient observations such as heart rate, respiratory rate, and oxygen saturation, and put them into the medical record, and all of the other details of the procedure such as the tube size, the type of feeding, and all. Okay. All right. If the explanation is clear, I hope, then let us see some video.
Dah, habis.
Video. Sekejap.
Video lagi.
Sekejap je untuk video ni. Okay. Can you hear?
Kuat sikit. Try lagi.
Boleh?
Saya tak pakai earphone kot. Sorry.
Okay. All right. We have a pH that is acidic, so our tube is in. NG2 placement in an older child can present challenges. What you see in this clip is a realistic scenario of a very nice boy who agreed to have the NG tube placed, but once the procedure began, he changed his mind. You see him kicking, crying, and even coughing during the attempt to place the tube. He was being treated for pneumonia, so the cough was expected but not helpful. I was also unable to cannulate the nair he initially indicated he wanted the tube placed in, so I had to go to the other side, likely due to edema of the nasal passage. Here, you can see I could not aspirate gastric contents after 2 attempts. We were able to tape the tube in place and turn this young man on his left side to allow for pooling of secretions. After a few minutes, I was able to aspirate acidic gastric contents. When you encounter situations in NG2 placement that are not textbook perfect, stay calm and keep talking to your patient to reassure him or her. The clips we have just shown you are not unusual in pediatric NG2 placement. NG2
So video tak bagus. Okay, next.
Me, Dr. Fatin Hanani. Fatin Hanani.
Topik.
My topic is endotracheal intubation in peds. Can you see my slide?
Yes.
Come, start.
My screen. Okay, Bismillahirrahmanirrahim. My name is Fatin Hanani binti Shafi'i and I'll be presenting about endotracheal intubation. So this is my outline presentation, starting with indication, contraindication, equipment and preparation, proceed with the procedure, and lastly will be the complication. So endotracheal intubation can be defined as the placement of a tube into the trachea, either orally or nasally, for airway management. It is to ensure the patency of the airway, and this is the gold standard for maintaining the airway and also providing the ventilation for the patient. And oral intubation is recommended in emergency situation, as is mostly infant can educate.
Continue. Apa? Continue lah. Kenapa?
Rasa internet.
Fatin, kenapa? Hilang. Fatin Hanani, kenapa?
Saya rasa dia terleft Pak.
Ha?
Sebab
He left the meeting, Doctor,
left.
Dia apa?
for some reason. I don't know.
Dia left.
We don't know. Yeah,
Maybe internet.
yeah, internet connection maybe.
Ya. Dia kat mana?
Dekat rumah.
Not sure,
Dia
Doctor.
kat mana? Kat mana?
Kuantan.
Konten okey lah internet dia.
Not sure, Doktor.
Kat Sabah memang lah. So hilang dia. Ya, problematik lah, tak tahu kenapa. Year 5 very small now. Year 3 tersiap lah. Dua suku agak something sempat tak sempat awal ni. Teaching dia all ni letih lah. Siapa next presenter?
Mi, Doktor. Asma.
Asma, topik apa?
Peak flow meter.
5 minit lagi tak dapat, you present lah.
Okay.
Nanti tunggu sekejap.
Okay.
Just 5 minit. Saya boleh recall dia, telefon dia, beritahu dia yang ni.
She said that the meeting freezes, and yeah, maybe she her laptop is problematic. Yeah.
Internet
Dia
dia
kata tersekat,
tersekat.
Doktor.
Dia
kata laptop dia
tak
tersekat.
bayar ke apa? Laptop dia tersekat.
Yes. Dia kata
Laptop
ada
dia.
je, dia kata ada je dalam meeting, tapi dia punya laptop tersekat. Yes. Freezes. Yeah.
Tak faham. Dia dah ada dalam meeting. Dia dengar kita tak?
I'm not sure, but
Dia dengar, bila
Yes.
dengar Asma presentation.
yeah, I asked her.
Dengar bila Asma presentation. Dia dengar tak?
Dia kata tak dengar, Doktor.
Tak dengar.
Yes. And yeah, she left the meeting, plus her laptop ada lagging.
Ada apa?
Lagging lag.
So dia nak try balik.
Sekejap, I ask her.
Dia try enter balik.
Yeah.
Dapat?
Dia kata dia minta next presenter continue.
Next presenter dulu.
Asma present lah.
Mungkin after Asma, mungkin
Asma akan
ada
present.
Okay.
orang lain tolong present.
Asma, you kat mana?
Kuantan.
Konten juga?
Ah.
Tengok okey ha.
Duduk sekejap.
Kat Acrobat ke? Okey ha.
Assalamualaikum warahmatullahi wabarakatuh. My name is Asma Anwar and I'll be presenting about peak flow meter. So what is peak flow meter? It is a small handheld device which is used to measure a person's maximum speed of expiration during a forced expiration. So as you can see in this picture, there are three parts of peak flow meter. There is measuring scale, indicator, and also the mouthpiece. So what is the uses of peak flow meter? Firstly, it is to classify severity of asthma, and I will explain it further in the later slide. Secondly is to see whether the asthma management plan is working or not. And thirdly is to decide when to add or stop medicine. For your information, peak flow meter, it is not usually applicable for children less than 5 years old because it is an effort dependent. So basically we can use peak flow meter as a disease as asthma monitoring. So for the procedure, I would like to show a video. Can you hear the voice?
No.
No.
Okay, I will just narrate it. So firstly, the patient can stand or sit up straight. Okay. Wait. And then the patient need to empty the lungs, breathe out, and then take a deep breath in, and then put the mouthpiece between the lips and make sure it is closed. And then need to blow out as fast and as much as the patient possible.
As hard and as fast as possible.
As far and as hard as possible. And then the steps need to be repeated 3 times and record the highest reading. So before each repetition, make sure the marker is level down. Okay. So what did we do with the measurement? As you can see, this is a table of a mean peak expiratory flow rate of normal Malaysia in children, and the indicator is the height and the gender. So based on this table, the formula is that to calculate the percentage, the patient highest reading over the predicted PEFR value according to the height and the age, and then need times by 100%, and then we will get the result the PEFR percentage. And after that, we can classify it according to the severity of the asthma. So according to this table, there are 3 zones of measurement. There are green, yellow, and red zone. So if the patient's PEFR reading is more than 80% of the usual, it is in the green zone. So what this indicates, that the asthma is under good control. If the reading is 60 to 80% of usual reading, it is in the yellow zone. It indicates caution, and this may mean respiratory airways are narrowing and additional medication may be required. So if the reading is less than 60%, it is in the red zone, which indicates a medical emergency, and severe airway narrowing may be occurring and immediate actions needs to be taken. So the patient need to consult the doctor for to alter the asthma management plan. So what are the advantages and disadvantages of PEEP flow meter? The procedure can be done within 1 to 2 minutes. It is inexpensive and simple and useful for frequent follow-up use. So it can be used for a daily monitoring of in asthmatic patient in a daily basis. But the disadvantages are it is very much effort dependent. So because of that, it is not usually applicable in children less than 5 years old. It is insensitive to small changes. And as you can see in the PEEP flow meter, the mechanical one, there is no like decimal places, but currently there is the digital PEEP flow meter is also available, but it is more expensive than the mechanical one. And lastly, is small airways cannot be assessed. So it is better to use spirometry, which measure the forced expiratory volume in 1 second, which is more sensitive to minor narrowing of the airways. So I would like to emphasize again that PEEP flow meter is usually not accurate for the diagnosis because of its variability, and it is not applicable for children less than 5 years old. So that's all from me.
Mari kita bersama-sama menaikkan solat dalam waktu. Kerana Nabi Muhammad SAW pernah ditanya.
Tak dapat video, tak boleh. Tak boleh juga video.
Line ke doktor, sekarang hujan.
Oh, iya. Hujan menyebabkan semua tu. Okey lah. Dapat. Fatin ni dapat.
Sorry, Dato, I asked Dul to present my slide, my screen, my slide, yeah.
Siapa?
Because
present.
Lokman.
Lokman lah, okey kang.
Okay, sorry doctor for the delay. Bismillahirrahmanirrahim. My name is Fatin binti Shafi'i and I'll be presenting about endotracheal intubation in pediatrics. Next. This is my outline of presentation, starting with indication, contraindication, equipment and preparation, procedure, and also lastly complication. Next. So first of all, the endotracheal intubation can be defined as a placement of a tube into the trachea, either orally or nasally for airway management. This is to ensure the patency of the airway, and it is the gold standard for maintaining the airway and provide the ventilation. And oral intubation is recommended in emergency situation, and because mostly infants are adequately managed with effective positive pressure ventilation using bag and mask ventilation. Next. So for the indication of endotracheal intubation, endotracheal intubation can be indicated in a patient with insufficient bag and mask ventilation where due to insufficient gas exchange and difficult mass ventilation due to anatomical or pathological reason. For example, for the anatomical reason is the large tongue, heavy jaw muscles, facial deformities, and also pharyngeal problem such as lingual tonsil hypertrophy. And ET intubation also can be indicated in the patient with insufficient continuous positive airway pressure, such as in patient with hypoxia respiratory failure associated with congestive heart failure, to improve the oxygenation and also improve the ventilation perfusion matching. ET intubation also can be indicated during the direct suctioning of the trachea. The tracheostomy suctioning is indicated after intubation to remove the thick mucus and the secretion from the trachea and lower airway that cannot be cleared by coughing. So this is to mobilize the secretion to improve the airway. And the primary indication is to maintain and protecting the airway to provide the adequate oxygenation and also improve the ventilation. And lastly, ET intubation can be indicated in the patient of newborn with diaphragmatic hernia to establish adequate oxygenation and also cardiovascular stability. Next. So for contraindication, it is contraindicated in newborn with diaphragmatic hernia. It is when the operator is inexperienced in doing the intubation, so they would perform the back and mask ventilation to help arise. So back and mask ventilation should be avoided in a newborn patient with diaphragmatic hernia because this is because it can cause bowel insufficiency and also bowel distension that can impair the function of the lung, and this is to avoid the high airway pressure. Next. So this is the anatomical importance of neonate, which is the fundamental distinct features of the pediatric airway compared to the adult airway. So for firstly is the airway positioning, which is neonates have short neck, which is in particular have shorter length of the airway and also smaller diameter of the airway. Next, the child also have larger tongue relative to the size of the oropharynx, and also they also have angled vocal cords. They also have different shape of epiglottis, which is in infant or children, they have larger and also curved and floppy epiglottis and floppy epiglottis. Next, they also have funnel shaped larynx, which is narrow as it goes downward, and the location of the larynx is more anteriorly. Next, they also have short and flexible trachea, which is narrow and less rigid. So all this anatomical importance can cause narrow of the field of the vision when assessing the airway. Next. So this is the summary of the anatomical importance.
You tak faham, proceed. Tak payah. Benda ni tak payah. You don't need to know. Yeah.
So
because something that I will tell you, macam ni baru you perlu tahu.
Okay, doctor. So for the equipment used in the endotracheal intubation, firstly is the bag and mask with high oxygen flow, or can also call as ampoule bag or self-inflating bag. It is used in the pre-oxygenation phase, where it is used to supply the 100% inspired oxygen till well saturated before the intubation. Next is the laryngoscope. The laryngoscope is a device that used to visualize the vocal cords to facilitate the intubation. This is to allow the insertion of the endotracheal tube. Next is the blade. There are two types of blade, which is the Macintosh and Miller blade. So the Macintosh blade is the curved blade, while the Miller blade is the straight blade. I'll tell the difference afterward. So next is the stylet. Stylet is the optional device used to guide the tip of the endotracheal tube into the trachea. This is to confirm the insertion of the endotracheal tube. Suction catheter also used to clear the secretion and to maintain the airway patency and to optimize the oxygenation. pulse oximetry is also used to monitor the airway of the intubated patient throughout the procedure. They also use the sedation, which is the midazolam or morphine, and muscle relaxant, which is the rocuronium and succinylcholine, to render the patient unconscious and to facilitate the placement of the endotracheal tube into the airway to avoid the risk of aspiration. Next. This is the main equipment, which is the endotracheal tube. There are two types of endotracheal tube, which are uncuffed tube and cuffed tube. Uncuffed tube is preferred in neonates, young infant and young children less than 8 years. This is because it is to prevent the airway from mucosal injury and pressure necrosis due to the narrowing of the airway. The cuff tube is used in older children, which is to avoid air leakage and for safety use during the treatment. The size of the endotracheal tube can be calculated by using the formula, the age of patient over 4 plus 4 for the uncuffed, and the cuff is the age of the patient divided by 4 plus 3.5. This is to estimate the endotracheal in the internal diameter of the endotracheal tube. Next. Endotracheal tube also can be the calculation before the formula can be used for the patient with age more than 1 year. For the child with
benda ni beritahu you. Dia boleh ingat ke nak keluar exam semua benda macam ni? Allah, kenapa you go complicated sangat? Tak apalah, continue you all ni. Tak apalah, continue.
For the there are a few laryngoscopic blade size, which is 0 for premature or newborn, and 1 and 2 for the 1 month to 2 years, and for the older child is 3. So next. These are the appropriate way to wear the mask ventilation. The correct one is used to the mask size must fit the nasal bridge and chin of the patient without covering the eyes. Next. The preparation first is to get the informed consent from the child's parent and explain the techniques, complications, and benefits of the procedure. Next, prepare the materials and equipment. After that, the patient's vital sign must be monitored throughout the procedure, such as the heart rate, respiratory rate, blood pressure, and also oxygen saturation. Next is the sniffing position. The sniffing position is a position that used to position the patient for the pre-oxygenation phase. Next is the ventilation technique, which is to ventilate the patient with 100% inspired oxygen until well saturated. And sedation and neuromuscular blockade can be before the intubation process. Next. Next. So this is the sniffing position. The position for the sniffing position is to position the patient for the denominated pre-oxygenation phase. There are 3 basic steps for infant, toddler, and also.
You're third year student. Third year student ni tahu basic ni cukup dah. No need to go in detail. You tak akan ingat punya. You tak akan ingat. Dan I thought you detail yang mana sometimes you tak akan ingat punya. You tak ada briefing ke apa tu, apa yang nak buat, apa nak present for ni procedure. Tak ada briefing. So you bantai lah semua. Continue. Your reason, is to understand saja. Faham? Because unless you want to take the exam for ni, nak take procedure, faham? Ni, because semua ni ada exam, kalau you know procedure dalam ni dah pass, dalam ni, then you go to very detail. The first one is to make you interested dan faham saja for ni. Bukan ni untuk you all tahu sampai ni seolah everything you need to know. Tak payah. Because you're not going to be. Once you become houseman nanti besok and then is you ni. Nanti you're very confused how much you need to know, how much you need to know. Because I beritahu you, this intubation ni it's very detailed, you can go, very complicated. So now you give very simple je, indication, techniques ni, then how to do it, finish. So you understand how is it. Bukan you don't need to go to very detailed technical. Very detailed technical tak perlu. Continue.
So we proceed with the procedure.
Procedure.
So there are 2 minutes video.
Ensure you have all the equipments ready for intubation. You would need another person to help you for providing the supplies, for assessing the heart rate, and for informing the oxygen saturation. Ensure strict asepsis during the procedure. Stand at the head end of the baby. Hold the laryngoscope in your left hand. Choose an appropriate size blade, size 0 for preterms and size 00 for very preterms. Introduce the laryngoscope blade, pushing the tongue away. Visualize the glottic opening. Clear the secretions as required. Identify the vocal cords and introduce gently the endotracheal tube. Do not force the endotracheal tube in position. If the baby takes a gasp, wait and then reintroduce the tube. Remember, there is no role for providing free flow oxygen during the procedure. Rise in heart rate is the first parameter of improvement. Further, bilateral chest expansion, equal air entry on both sides of the chest, absence of abdominal distension, improvement in color, improvement in tone confirms that the endotracheal tube is in appropriate position. Endotracheal tube must be fixed securely. Cut the endotracheal tube 4 centimeters, extending beyond the lips to decrease the dead space. Thank you.
So lastly will be the these are the steps. It's just the same. So lastly will be the complication. First
Video tadi dah cukup dah for you all. Continue. Complication.
For last one is the complication. The first one is the esophageal intubation. It is due to displacement of the endotracheal tube into the esophagus due to dislodge. Next is the right lung intubation. Right lung intubation is rare, but it's more often on a right main bronchi due to anatomical reason, which is the right bronchi is more vertical and it can cause respiratory compromise and worsen the hypoxemia. This is due to accidental endobrachial intubation. Next is the trauma to the upper airway, which is the soft tissue that can cause soft tissue injury to lips, buccal mucosa, and also a floor of the mouth and palate during the insertion of the endotracheal tube. Next is the pneumothorax. Pneumothorax can be caused due to high positive pressure during the mechanical ventilation, and it can cause the air to leak into the space and cause the lung collapse. And the last one is the subglottic stenosis, which is the long-term consequences of the prolonged intubation that can cause the localized tissue ischemia due to excessive pressure exerted and leads to vascular damage, edema, and also granulation that more predisposition of and there will be ulcer formation, and the deposition of the collagen leads to the scar formation and contraction of the tissue that lead to stenosis. So that's all from.
Next, any questions? Okay, nanti for you nanti I will, because I think then the dangers of technical things that you going to get boring. No, you don't understand. The most important for you all is to understand the procedure, the indication, contraindications, and the basic thing, basic things to do, and then the step to do. No need to go to very technical, because the technical part is something that you will learn when you on practice on yourself, or when you become you doing it yourself, practice. When you doing yourself when you are doctors, then that is a technical. So because you what the function, the teaching is for you to understand the procedure. You understand not? To you to understand procedure. Bukan, it's not for you to do the procedure. It's not for you to do procedure, but to understand the procedure. Because you see, sometimes I found out you go so very technical. No, I don't think you all can understand what is it now. Next, siapa lagi seorang? Siapa?
Saya kata.
Luman, okay.
I present on chest drainage. Bismillahirrahmanirrahim. My name is Ahmad Luqman bin Zulkifli, and I'll be presenting on chest drainage. So here is my content. I will start with intro, indication, relative contraindication, the management and some of the complications, the procedure and the criteria of removal. So a chest tube, also known as a tube thoracostomy, is a common procedure in which a tube or a small catheter is placed through the chest wall into the pleural cavity. This is for to drain air or fluid. It also can instill agents to induce pleurodesis. Pleurodesis is a procedure that uses medicine to adhere lungs to the chest wall. So these are the indications: pneumothorax, where a condition, the lung is collapsed due to the presence of air in the pleural space, where the intrapleural pressure is equal or greater than atmospheric pressure. Some of the pneumothorax is spontaneous pneumothorax and tension pneumothorax. Thoracostomy also indicated in hemothorax, where the blood is present in the pleural cavity. It can be due to the chest trauma, post-operative following a thoracic or abdominal surgery, or a non-traumatic cardiac or aortic condition. This procedure also indicated in pleural effusion, where the water build up in the pleural space. Next is the relative contraindication. What is meant by relative contraindication? For example, if the patient has these conditions, we have to think whether the chest drainage needed to be done or not. This is by we're looking at the severity of the patient. If the patient can hold on without any chest drainage, we might not want to do the procedure on the patient. Some of the condition when the patient is on anticoagulant, or the patients have coagulopathies or overlying infection. Next, the management after a chest tube has been inserted. management and removal of the tube is the same for adults and pediatric patients. And the complication, some of the complication is a malposition where it may represent a form of penetrating trauma and it should be managed accordingly. Thoracostomy also can lead to infection such as empyema and pneumonia. This is because the increasing duration of chest tube placement, it increases the risk of infection. This tube thoracostomy also can injure some of the organ or artery or nerve, and the most common injured organ is lung, and followed by the heart, liver, spleen, and so on. Tube thoracostomy also can cause pulmonary edema. The complication also might happen during the procedure and post-procedure. So these are the lists you might want to see it afterwards. Next, we go on to the procedure. I divided into preparation, the equipments, some of the techniques of thoracostomy, and the steps. Inside the preparation is the antibiotic prophylaxis. The need for prophylactic antibiotic. Oh, no need?
Tak apa ni, dia tak nak pakai pun pediatric. Continue.
Oh yeah, it's only for adult.
For
the patient is
continue.
Even no need.
No need.
For the children, for the pediatrics.
You are lecturer of procedure. How to do the procedure. Bukan you nak buat lecture from tu history, physical examination semua tu. You consider dah settle semua tu. Continue. Yeah, this one
This one is particularly important for the pediatric patients because we need to consider the patient's length or the size relative to the age, and as well as the body habitus. And according to the pediatrics protocol, for a patient who is less than 2 kilograms, we need to select 8 French diameter. For more than 2 kilograms, we select 10 French diameter, and for the older children, can select from 12 to 18 French diameter according to the patient size, body size. So these are the positioning of the patient while doing the procedure. It is preferred in sitting in supine position, and the head of bed is elevated 30 degrees. In elective setting, oral, intranasal, or intravenous sedation can be administered prior to the tube insertion, in addition to local anesthetic infiltration. Non-critically ill pediatric patient may require additional distraction, as this procedure is very invasive and can be painful for the patient. To note that lidocaine is the most common local anesthesia used in clinical setting. For us, I think we need to know the maximum allowable dose to prevent toxicity. This is the maximum allowable dose. The tube is inserted at the 4th or 5th intercostal space in the anterior axillary or mid-axillary line. According to pediatric protocols, it said it is at the 4th intercostal space, mid-axillary line. These are some of the equipments. Moving on, we will see some of the technique used in thoracostomy.
Position the patient supine at a 30 to 60 degree angle to lessen the risk of diaphragm elevation and subsequent injury. Raise the arm on the affected side so the palm lays behind the head. Identify the 4th or 5th intercostal space just anterior to the mid-axillary line. Apply lidocaine for local anesthesia at the planned incision site along the expected course of the chest tube and then at the periosteum, intercostal muscles, and the pleura. Aspiration of blood, air, or pus confirms entry into the pleural cavity. Apply a clamp on the chest tube at the desired length of placement. Create a 4 centimeter horizontal incision at the rib below the desired level of entry. Use a Kelly clamp to bluntly dissect a tract through the subcutaneous tissue and into the intercostal muscles. Palpate the tract with a finger, confirming it ends above the rib. With a large closed Kelly clamp, insert the clamp through the intercostal muscles and parietal pleura to enter the pleural space. A distinct pop will be felt. Listen and feel for a rush of air. Open the Kelly clamp in the pleural space and withdraw to further dissect a tract. Insert an index finger through the tract and rotate 360 degrees to loosen adhesions and confirm the tract. Grasp the fenestrated end of the chest tube with a Kelly clamp and introduce it into the pleural space, posteriorly and superiorly. Connect the chest tube to a drainage device and release cross clamp. Secure the chest tube in place with a suture and dressing.
So next is another technique. For this technique, it is more useful for smaller bore tubes that reach air and non-viscous.
Okay, so that's going to be the kit that we're going to be presented with when we're looking at a Seldinger chest drain. So if we just open it and go through each bit in turn. And it's wise to check through your kit before you do any procedure, just to make sure you're familiar with everything. So piece by piece, we've got the scalpel for the skin incision. Got the introducer needle, the wire's going to be fed along. And got the syringe that attaches to. Got the guide wire that we're going to be placing down the introducer needle. The bevel on the end will unscrew, and then the wire can be fed down. Just moving it between your finger and your thumb. Put that down. Then once the wire's in, we're going to be using dilators. They're of different size, and they've got little stops on the end of them to indicate at which point you're going to dilate up to. Varying thickness. And you then got the drain, which has got a stylet down the middle of it to feed along the wire, and that will unscrew and come out of it. And then finally, to attach to the drain, we've got the end teat, which is screwed on and attaches onto your drain. Right, so I'm going to start off just by identifying our landmarks and coming down to the right intercostal space. I'm going to clean and infiltrate with lignocaine. Then we're going to make an incision in the skin. Not as big as for an open chest drain. Okay. then going to get our introducer needle and our syringe. Okay, and we're going to aim this into the chest through that incision, aspirating as we go until we find we're in pleural space. Disconnecting the syringe, holding onto the needle. Okay, then going to get our guide wire, place that in, and advance that. Into the chest. Okay, keep your hand on the guide wire all the time. Take the needle out. Get rid of that. Okay. And we'll take the introducer. And we'll just pass that onto the wire. Dilating up our hole. Okay, take that back out. Go to the next dilator. Dilate that up. And finally the biggest dilator. And dilate the hole to the biggest maximum diameter. Okay. Then we get our drain, which has still got the stylet coming down the middle of it. I'm going to advance this until all the eyelets are actually in the intrapleural space. So again, advancing that through, making sure that don't let go of the guide wire. Okay, and then when it's come out the other end of the tube, hold on to that firmly and advance the drain down the tract you've just created. Okay. Then take the guide wire out. You can then unscrew the stylet from the drain. Taking that out, being aware you may have fluid that comes down the tube when you do that. And attach your three-way tap, closing the drain off for the moment. Screw that on. Attach your drain connector, which goes off onto the drain tube, and then just suture that in place. And then check you're in the right position with your X-ray and your clinical examination.
So next is another type of thoracostomy, which is called needle thoracostomy. It is best when immediate decompression is needed. This is usually done in emergency.
Though there are many ways to needle a chest in the case of a thorax, let's take a look at a refined version of the technique featuring my colleague, Gary Geis. Performing a needle thoracostomy begins with selecting the appropriate site, in this case the second left intercostal space. Next, clean the area with chlorhexidine or betadine. Have your equipment ready ahead of time. This includes a stopcock attached to extension tubing and a 60 ml syringe. Attach a 14-gauge angiocath needle to a syringe filled with saline. Insert the needle over the top of the rib while aspirating, looking for air bubbles. These bubbles indicate that you are in the pleural space, which is filled with air in the case of a pneumothorax. Next, thread the catheter over the needle, removing the needle and syringe, and hook up to the extension tubing. Adjust the stopcock so that it is open to the syringe and pull back until you feel resistance. Once you have pulled off the desired amount of air and the patient stabilizes, you can then close the stopcock, thus closing the system. If the patient decompensates, you can open the stopcock again to pull off more air.
So these are the steps. I think you can read later after. So these are some of the components which included in the equipments. Underwater seal is a system that allows drainage of pleural space using an airtight system. It acts as a one-way valve. And suction pump is to provide suction power to drain out fluid or air from the pleural space. And lastly is the criteria of removal. The test tube needed to be removed as quickly as possible to minimize the risk of infection. However, there are some criteria in order to do so. For pneumothorax, when the lung is fully expanded and no visible air leak present, and the air does not accumulate when the suction is removed, then we can remove the tube. For in case of empyema, and the lung is adequately expanded, and the majority of fluid has drained and the patient is doing well, no fever, no leukocytosis, and retained appetite, then the test tube can be removed. That's all. Thank you.
Okay. Any questions? Okay, the first NG orogastric insertion. Okay, about the video is ni. Intubations, okay. Flow, okay. Tak dapat video juga. Chest ni dulu. Okay. You see, picture can give you 1,000 words or better than you 1,000 words or like the chest drainage. It's nice if you have the picture where they do the drap, they do aseptic technique or those things, and then you proceed. Then you don't need to put it inside your explanation because you already explain inside the video. You have to find there is to be the video. It's better you search and search and search. I tell you because the final year can present the video which show how they drag the patient properly, how they how they decontaminate the skin and so on. They can get it. Better you search only. Okay, otherwise the video okay lah. The 3 techniques okay. But the 3 techniques is St. Leger is more expensive. You have to do ultrasound first, the position, you have to locate X first where you want to do the chest tube, and then you have to do the ultrasound guidance. So when you enter also you have to do ultrasound, tengok where the end of the tube. No, before you don't enter, you still have to do ultrasound. No, is there when you put in is inside the place you want to do it. To place inside. Second thing is even if some people use fluoroscopy, and then do this St. Leger technique. It's more expensive. Satu set get 2,000 ringgit. The surgeon like to use that way, but the technique is less traumatic. And then that's all. I mean, for you all, you just know that for your 3rd year, no need to worry about it's not it's not for you. This session is not you to learn until you know how to do it. This session is for you to understand the procedure. What is procedure all about? That's all. Actually, you finish by 20 minutes per session enough already. You don't need to go 30 minutes, 40 minutes, tak perlu. 20 minutes, just present briefly the procedure, and then after that the technical technique video finish. That's all. Tapi you all not briefing because I think most of your teaching tak ada learning objective. Ada tak dia bagi juga the paper the information what's the learning objective of every like procedure, what's the learning objective? Ada tak ada send to you all? Tak ada.
No.
I don't have time to do all those things yet. Nanti with your next group, the next one complete on. Because you all know how much because you see like intubation. Intubation is one whole book. It's one whole book, satu buku intubation. Intubation alone. Are you going to tell us all those things? Intubation? We give you satu hari lecture, we'll have satu hari lecture pun tak habis what intubation all about from technical, physiological, pathophysiology, the difficulty, complications. Is the techniques, how the technique to bag, how to look to the patient during bagging, what to look during intubation, when to stop intubate, what to look, aspiration, so many things for intubation. But this is the thing that you don't need to know at the moment. Okay, any questions? Kadang-kadang ada yang paling short sangat. Sampai 5 minit dah habis dah. Dah habis dah. 5 minit. Ada your final year students orang 5 minit dia present dekat. Very short. Any questions? Tak ada? Markah I tulis dalam ni nanti you minta bila you datang. I tak tahu macam nak hantar ke you all markah. Okay.
So nanti ada case presentation. Besok.
Besok pukul 3 lah. Pukul apa? Pukul 2? 2:30? 2:30 lah.
Discuss pukul 3. Tapi kau lah boleh je. Sebab schedule kosong.
Kat rumah tidur je. Tidur makan apa je buat kat rumah. Bukan ada apa pun. 2:30.
2:30 boleh datang?
Pukul 5 tu ada final, kena beri lecture untuk final year student. Dia dah kata nak cepatkan sikit pukul 4. 2:30, pukul 4, 4:30 belum habis. Kita pilih 5:30. Okey Okey. Okey, selamat tidur.
Okey Dato.
Tidur makan tidur.
Kalau tak ada.
Besok 2:30 kan? Doktor cakap kan 2:30.
2:30.
Last session.
Tak present.
Nak ada simulation ke malam ni?
Boleh tak?
Bincang last.
Dah tanya Luffy semalam. Luffy cakap dia nak buat tak? Okey je.
Yang case presentation esok ke? Kena ada simulation ke? Saya rasa macam terus present je. Terus
bagi channel.
Tak tahu lah, tengok lah esok kena bayar macam nak ada.
It's okay Fatin.
Sorry korang.
Let you. Heads up.
Okay Fatin.
Thank you.
You're a strong
Malam ni
girl.
Amani sana okey malam ni?
Okay.
Macam kita orang dengar je lah, nak komen pun tak tahu nak komen apa pun kan.
I mean we can always macam help.
Kena tambah-tambah backup.
Alright, selamat tidur kata doktor.
Selamat tidur.
Alright guys, good job guys.
Jom. Alright. Malam ni.
Bye.
Jom tidur.